our webinar to our first speaker for today. And in the sense of time, well, I will introduce Winifred Quinn. So Winifred Quinn is the Director of Advocacy and Consumer Affairs at the AARP Center to Champion Nursing in America, where she works across the AARP to help address public policies that intersect with consumer and nursing issues. Her state-level policy work entails organizing technical assistance to action coalitions and AARP state offices that are improving funding for nursing education or modernizing the scope of practice laws. And Dr. Quinn, we're so glad you could join us today.
Thank you so much, and thank you to Dr. McCauley as well for inviting me to join you today and to represent AARP, and for inviting AARP. I very much appreciate the invitation, and I'm honored to be here. And thank you to the committee on improving high quality primary care. Thank you for your service. So I want to talk about the primary care and its definitions. So I'll talk a little bit about the definitions of primary care, and then I will talk about why, basically 3 factors in how we see now that it doesn't really exist, and then I will provide some recommendations. I know we were supposed to provide one, but I'm going to sneak in a couple more. So we see the National Academy of Science, Engineering, and Medicine's 1996 definition of primary care, and we see AARP's definition of primary care. And I want to point out that primary care definitions, to me, are social constructions and language that were created jointly by insurers and others who pay for primary care and healthcare in general, as well as the clinicians. And it's a set of definitions that help to have a basic understanding of what care should be provided and the actions of that care delivery. And, but in reality, these definitions are not experienced by patients. And we see that the pandemic, the COVID-19 pandemic, has opened up the window, has pulled back the curtain, and allowed all of us to see the lack of coordinated care, the basic care needs provided in the community and in nursing homes, and that it especially is absent for the most vulnerable populations in the nation. And so if we look at those populations, those vulnerable populations, we're looking at people in nursing homes, and we're looking at the African American communities, the Native American communities, and the Hispanic Latino communities. So the data show, and I will send my notes, Bob and Linda, to you afterwards. I don't have access to them right now, so that you could see where the citations are that I'm using. So about 25%, about a quarter of the COVID-related deaths in the United States have been experienced by people in nursing homes. Just about 26,000, actually just short of 27,000 of the 103 COVID-related deaths as of 2 days ago were experienced by people living in nursing homes. We also know that about 20 to 21% of COVID-related deaths have been among the African American population. The weighted statistics show that about 26% of COVID-related deaths have been among Hispanic, Latino communities, people in this country. And an example of the Native American population and the disparities among them is that in New Mexico, the Navajo tribe, actually Native American people altogether comprise about 11% of the population, and yet comprise about 50% of the overall cases of COVID in New Mexico. So why the disparities? So I would like to focus on two major reasons for the disparities, and one is racism. The racism in the United States. Numerous medical organizations and associations, as well as nursing organizations, have defined racism as a public health issue, and therefore is a social determinant of health. I would also say that another factor for the disparities is that the clinical workforce that serve our nation does not reflect the communities that are being served. And we know that when we have, for example, I can speak to nursing, especially the nursing clinical workforce, that when nurses reflect the communities that are being served, especially for the vulnerable communities, they are more likely to understand these social determinants of health that the patients are experiencing and incorporate those social determinants of health, including racism, into the care that those people need. So a more diverse nursing workforce, and I would therefore generalize that to say a more diverse clinical workforce in medicine, in mental health, pharmacy, you name it, we would be more likely, this nation would be more likely to see health equity and significantly less healthcare disparities. Another part of the definition, especially the National Academies definition, is accountability. And we see that accountability is lacking right now. Again, if we look at the nursing home issue, there are the nursing home administrators or the nursing home owners are not being held accountable for the conditions in which their residents are in the context of the pandemic. And in fact, the current COVID relief bill is being held up in the Senate because the US Senate, because there is a debate about accountability. So there are some senators who would like healthcare delivery systems, including nursing homes, to be held accountable for the disparities and the lack of care and the neglect. And there are some policymakers who would like to not hold them accountable. So there is a lack of accountability, sadly. And I would also say that another very important factor to look at in terms of primary care and the lack of primary care is the lack of direct access that patients have to tens of thousands of highly skilled clinicians who are nurse practitioners, clinical nurse specialists, certified nurse midwives, and the nurse anesthetists. So when definitions of primary care were created, so here we have 1996, there were some advanced practice nurses, such as nurse practitioners, but it was not the sector that it is today. And so without being able to be at the table, any of the newer sectors that are highly qualified to provide primary care and well-skilled and do provide very high primary care are not allowed to be providing that care in most states. Okay, I have to wrap it up. So in terms of recommendations, I have one recommendation for each area. So for nursing homes need to have better staffing ratios. If possible, it would be great if nursing homes could be redesigned so that each resident would have their own home. But better yet, what we need is Medicaid to direct more funding so that people who need long-term primary care and support services can stay at home to get that care and not be forced into institutions where the care is lacking. Another part is that we need a more diverse nursing workforce and clinical workforce, and that could be done through the HRSA funds available to all sectors, clinical sectors, as well as graduate medical education. A segment of all of that funding could go to a more diverse and inclusive clinical sector. Going back to nursing homes and all care, accountability needs to be included. And finally, all states and where relevant, federal policies need to be modernized so that all advanced practice registered nurses can practice to the full extent of their education and training. And with that, I'll wrap up. And thank you.